So this is the video blog of the written blog post that was released earlier this month on non-specific low back pain. In fact, it's our first blog post that we've ever done, so of course would be interested to know how you found this video, if it was informative, or any recommendations on how it could have been presented slightly differently. But today's focus is looking at the term non-specific low back pain. We're going to have a quick run through what that term means, why that term is used, and how people can manage their back pain even if they have a diagnosis that by and large is non-specific. So what is that term non-specific low back pain? As I've said, it's a term that's expressing we can't identify a specific cause for back pain. And in fact, it's appropriate in most cases of back pain. Why do we use this term? What value does it have? Well, the reason for using it is we don't fully understand all of the ways in which pain is processed and the way that it is even generated. We have an idea on certain aspects of that, but we certainly don't have the full picture. So we have lots of scenarios where people will suffer pain in a certain way without a clear reason for why the pain is behaving in that fashion. Sometimes it can associate to a specific injury, which makes a lot of sense for people. If you're harmed, it hurts. But also we can see many scenarios where pain is occurring where there is no injury, or where the injury that had occurred has now fully recovered and fully healed. So because of this complexity within the way that pain behaves, that adds to the difficulty of identifying what is the source of the pain, because the source could be from numerous elements of that pathway, from the injured tissue or once injured tissue through to receiving it in the brain and interpreting it as a pain signal. So why use this diagnosis? Well, it more fairly represents what's actually occurring, in that we don't really have a way of identifying exactly what the source of the pain is. But where labels are placed on specific things, for example, your pain is the result of core weakness, or is the result of a bulging disc or an injured disc or a damaged disc, is the result of wear and tear or osteoarthritic or arthritic changes within the spine. Sometimes that can lead to people becoming more fearful of that injury or the term that's been used there. And that fear can actually inadvertently reduce the way that they would interact with their back and their pain. It might make them less active, less mobile. And these things in fact can contribute to higher pain levels or more chronic or ongoing pain natures. So actually removing the fear of how people can engage with their pain is a really key and important part of assisting their recovery. So the term non-specific can provide some assurance, even though it doesn't help to provide something clear and precise, in that it changes the way we look at the pain and it changes the way we choose to interact with the pain. So the diagnosis is maybe more accurate, even though less specific, for understanding that we have a range of things that could be contributing to the pain, both from a physical aspect of an injured tissue or a tissue creating a pain signal, right the way through on a broad spectrum to how the brain is receiving the signal, processing the signal, and how that's being interpreted. And this is where that complexity that I keep referring to comes from, all the way through this kind of pathway. So the diagnosis I find is very useful with patients to help take away some of the fear and to engage with their pain in a much more positive way that actually is going to drive them towards a more successful recovery. Absolutely yes. This is something I see in practice very often. Cases of people with back pain where we struggle to find a specific or identify a specific cause. And what you do is you end up looking not at what we think the pain is coming from, as in do we think it's a disc or do we think it's a joint, but more looking at what is the individual finding difficult, what actions are more limited, what movements produce pain, what activities are being reported as being painful or aggravating to the pain, what's the pattern we're seeing to how the pain is behaving. And then with all of that information, we can start to create a treatment plan that is going to address each of these areas. Encourage people to steadily improve mobility in a range that is more restricted. Look to ease the discomfort of a certain movement to make it more comfortable again. guide a certain activity so that we've got a phased progression or a phased return back into it that controls pain and allows pain to be tolerant for the activity and therefore do the activity pain-free. So the focus doesn't become about targeting a specific tissue, it becomes much more about targeting the function of the individual. And this could almost be interpreted as a slightly more holistic way as well, because function can be looked at as how the body is moving, not just how one specific area is moving. So you absolutely can recover, we just shift and change the focus of how we're kind of coming at this, moving forwards from there. You find that there's a lot of evidence that now supports things like active lifestyles, certain strength and conditioning into regions, mobility exercises, stretching exercises, manual therapy, things like kind of deep tissue or sports massage of the region, mobilizing techniques, maybe even manipulative therapy where the techniques produce a click sensation through the joints. All of these things can be beneficial to pain. It's of course important to select the appropriate method depending on how the pain responds and whether it's favourable or not, and to select the intensity of each of those individual elements as well, because it might respond well to, say, a light brief walk, but not very well to a high intensive power walk or an hour's walk. So we need to find not only the right activity it responds better to, but the right measure of that activity. And the same with any kind of hands-on techniques or treatment techniques that go in there as well. Not just about the selection of the techniques, but the measure of them as well. If you find that you're doing an activity that is heightening pain, the risk of injury and damage is actually really, really low. You're very unlikely to further harm your back or injure a tissue because you walked too far and the pain increased, for example. But what you will do is heighten pain sensitivity. And one thing we find is if we have a pain response, again, because there's lots of things that can influence how that pain behaves, one of the things that can make it worse is if we keep overstimulating that pain. We keep doing things that drive the pain levels up quite high, and it's going to keep that pain element more active, and it's going to create a bigger protective response from your body where it heightens the readiness for the pain to react as well in an effort to try and safeguard the region. So it's about introducing an activity that gets mobility and movement and something engaging. It's about doing it to the right level so that we don't have an overstimulus of pain. And some people will be very confident in experimenting with these elements, but many would much prefer to have some degree of professional guidance on how we're going to introduce these things and where the appropriate starting points may be and what the appropriate rates of progression could be as well. That is certainly when you might consider contacting people like ourselves here, where we can go through all of those details with you. But absolutely, though we're using a non-specific term to identify what we think the source of your pain is, or more that we aren't identifying the source of what the pain is, there are still many things we're going to be utilising and engaging with that's going to get you on your pathway to recovery and also work to potentially reduce the frequency of any recurring episodes in the future as well. So, would an MRI scan assist in giving us a clearer picture? I mean, this is something I hear very frequently in clinic. Patients sometimes being frustrated that the GP hasn't referred forwards for further imaging at the moment they told them about their back pain, even though their back pain was extremely severe, or the fact they've come into clinic and they're quite keen for us to maybe move on a private scan so that we can understand the problem before we try to resolve it. Well, unfortunately, we now have quite a lot of data of MRI scans on pain-free individuals. There's been thousands upon thousands of MRI scans on pain-free people. And the rates of finding injurious tissue in the back or pathology within the low back is actually really high. The study stated that there was a 50% of the 40-year-old population demonstrated disc injury on a scan. 50% of all 40-year-olds in the general population will have a disc finding on a scan. So that goes up as we go up through the age ranges. It's 60% of all 50-year-olds. That means if you've never had a day's back pain in your life and you're past the age of 50 and you have an MRI scan and there is no disc finding, you're actually the abnormal finding, because it's normal by that point for people to have some degree of finding on the scan. So a scan result doesn't provide that clear picture. It provides a piece of information, and in some cases of back pain that information could be associated in a way that's relevant. But in many cases of back pain, actually the finding is a bit of a query or a question mark, We don't know if it's a coincidental finding and has nothing to do with the pain, or is actually an active part of the pain complaint. Because the scans, MRI scans, can only tell us a picture of what they've seen. They can't tell us whether that disc finding or wear and tear change or arthritic change or degenerative change is actually actively inflaming and painful at the same time. There's also been studies that have looked at, well, does an early MRI scan actually improve patient outcomes? And the answer to that is no. We don't find people recover quicker for having had a scan. We don't find that treatment can be guided more specifically or can target the pain more successfully. There was also a study with the Farringham Heart Study where they looked at extent of osteoarthritic change, so wear and tear change, identified on MRI scanning. Could we associate a severity of osteoarthritic change with the severity or the nature of low back pain? And they couldn't. People can have osteoarthritic changes that are quite significant on a scan but have no back issue whatsoever. So these findings are very, very grey as to the extent of information they provide. There are some scenarios, though they are very rare, where something more urgent as a scan is really needed, and the severity of back pain often isn't one of those guidelines. You can have really awful, severe pain, but actually the cause be quite innocent or even very difficult to identify at all. There are other indicators that healthcare professionals would look for to try to identify whether there is an urgency and a need for the scan in that scenario. And I would certainly impress upon you to engage with a healthcare professional such as the GP or a physiotherapist or an osteopath to help make that call on whether a further scan is actually needed in that instance. But what we're looking at from the scan perspective is I only tend to refer people forwards for scans or recommend for scans if we feel that that individual is on a pathway to needing something further as a solution to their pain. And that pathway might be moving on to orthopaedic consultants to start to review a range of additional kind of options in through from there. But that's quite rare. A vast majority of back pain cases will recover with conservative care and good management. So the scan doesn't lend itself to provide any additional information. So early scanning, not really something you want to be considering unless your healthcare professional identifies an urgency to do so. So a final summary of what we've kind of covered today. Non-specific lower back pain is a non-specific term that is used to identify that we have back pain, but we don't really have a specific cause that we've managed to pick out there as a root of that. That doesn't have a negative influence on the rate of recovery because recovery plans are focused much more on the function, the movement, the disability that the pain is causing as we kind of move people through that pathway on a road to recovery. And we don't really look to put people forwards for early MRI scans because they don't provide a clear image that tells us what the source of pain is. They provide a degree of information which in most cases of back pain isn't particularly relevant nor helpful in aiding the choices of how you move somebody forwards within their recovery. So if you are suffering with back pain and it's staying local to that low back region and you would like more advice or more information about the best way to manage, recover or engage with those pathways, then do feel free to get in touch with us and we can certainly provide some advice and see what we can do to help.